good morning, everybody. We are very delighted to welcome today Mr. Shad Khan, who is a consultant endocrine surgeon at Oxford University Hospitals since 2018. He's the clinical lead of the endocrine surgery department there and works closely with the endocrinology teams looking after patients with MEN syndromes. And Oxford, in case you didn't know, is one of the UK's highest volume parathyroid and adrenal surgery centres in the UK. So welcome, Shad. Is that all right to call you Shad? Since
of course.
We work together on
closely.
AMEND, so hopefully that's all right. So we're talking today about parathyroid surgery, but just to sort of give it a little bit of background before we get to sharpening the scalpels, as it were, could you explain a little bit about what parathyroid hyperplasia actually is?
Well, thank you so much for having me on here. It's a real pleasure to be able to speak with you all today. So diseases of the parathyroid gland are very, very common in MEN1 syndrome. It's one of the commonest manifestations. And MEN predisposes one to getting what we call hyperplasia of the parathyroid glands. Now, this is a distinct entity from the traditional disease of parathyroid glands, the adenomas, where you get a tumor that grows, if you like. And when we look at these histologically, that is under a microscope, they look quite different in their appearance. And hyperplasia refers to a generalized growth of the whole gland throughout the whole gland. If you like, it's a bit like a muscle that's been overworked. The whole muscle is enlarged rather than just a few cells that have started to grow and become a solitary tumor. That would be an adenoma, which is far more common, but hyperplasia refers to the whole glands being generally enlarged, and it usually affects all four of the glands. Now, it's worth mentioning that it can affect the glands differently. Some can be larger than others, so it's always you've got to be very careful to be sure that you're not missing a case of hyperplasia when operating on someone. But MEN specifically generally predisposes one to get hyperplasia of the glands. So generally we find eventually over time, all four parathyroid glands might become enlarged. And it's also worth mentioning at this point, in case I don't later, that you are also possibly more likely to get in more numerous glands and in more ectopic positions. And that will hopefully come to a bit later when we talk about surgery.
Yeah, and that I think is a little bit more MEN1 sort of veers towards the more than the four traditional glands rather than the other MEN syndromes. Yeah.
Yes, indeed.
Yeah. So MEN-related hyperparathyroidism, how is it different from sporadic or non-genetic hyperparathyroidism?
So when someone comes in with hyperparathyroidism, we classically tell them that there's a roughly 85% chance there's a single gland causing their disease. In 10% there might be two glands, and only 5% there's going to be hyperplasia, that is all four glands affected. And of those patients have all four glands, we do usually recommend multi-gland disease does get investigated for MEN, because a small proportion of those hyperplasia will have MEN syndrome, and it's worth picking that up early for the patient's sake, for their family's sake, and looking at other things around the body as to what might else be going on. With regards to the actual disease itself, well, there's not much difference, especially surgically. We will approach this rather similarly, but there are conditions that can predispose one to getting hyperplasia, so MEN being the classic one, the genetic ones. Some drugs, such as lithium, can cause the parathyroids to generally grow, and that can give similar appearance. And also having chronically low vitamin D levels, what that does is it chronically stimulates the parathyroids, which have to work harder, and over time they grow and can cause this, hopefully to a smaller degree, but of course the treatments would be different for each of those. And MEN parathyroid hyperplasia, you'd want to try and manage surgically where it's appropriate, and of course we'll talk about that a little bit later. But no, the approach to hyperplasia would be rather similar, but I think you would expect in MEN syndrome to get slightly more enlarged glands, especially the longer you have the disease.
Yeah, okay. So how do patients typically present then when they have parathyroid hyperplasia? I mean, can they present with no symptoms? And if they present with symptoms, what sort of symptoms are common?
Yeah, absolutely. So there's a good cohort of people that come in with no symptoms, and it's just picked up on a routine blood test one of these well-being checks that people are getting done more and more often. If there's a family history, then of course we would start checking calcium levels a bit early, and they may well come in with slightly elevated levels and no symptoms whatsoever. Other people will get more symptoms as time goes on, and possibly as calcium levels increase. We do like to think that there is some degree of correlation, but it's a very weak correlation with symptoms. And those early symptoms include things like generalized aches and pains, that they include being excessively fatigued and tired. But it's worth mentioning that a lot of these symptoms, if you go around to the general public, in this day and age and say, do you have any of these symptoms? They're very, very common. So these more what we call neurocognitive symptoms are very difficult to differentiate whether they are parathyroid related or whether they could be just due to something else. And that becomes important later when we're talking to people about surgical cure and what we're hoping to achieve with that. Then, of course, we get onto the more problematic issues of very high calcium, where it can really become quite dangerous when calcium becomes over 3, causing problems such as kidney stones, osteoporosis, weakening of the bones over time, but also in the acute setting can be quite dangerous with regards to having such a high electrolyte for your heart and for the brain.
Yeah. Do the symptoms usually correlate with the blood levels? So when you test the levels, does that seem to correlate normally?
We get asked this question quite frequently, and it's a very difficult one to answer. The data is quite difficult to interpret, especially when it's a question of asking patients about their symptoms. On the whole, I tend to think not, if I'm honest. And now we do have a stance where we try to say below a level of 2.85 in the UK. This is a calcium level of below 2.85. You're less likely to be symptomatic. But we've all seen clinicians, we've all seen patients coming in with levels lower than that, being significantly symptomatic and being cured when they're better after surgery. But then I'll also always remember this story of being called by the hospital laboratory one afternoon about some patient who'd had a blood test under my name, and they called me to say the calcium level was almost 4, which is really quite extremely high. And of course, the first thing we say is, please recheck that. And they said we run it 3 or 4 times, and it was a patient that had been seen by one of the team. So I quickly got on the phone, called this lady who was very out of breath. It was a lady in her 70s, and she was very out of breath. And I was thinking, oh God, what's happening? Is she having a heart problem? And it turned out she was at the gym, and she was completely asymptomatic on the treadmill doing some sort of workout, which is fantastic. And I had to say, okay, well, just slow down. Do you mind coming straight into the hospital? And we got admitted to the medical team, repeated everything. It was indeed for. So very high calcium levels, we think, would make you very symptomatic, but there are those odd stories where you don't get symptoms, and likewise, you can have patients with calcium slightly elevated, but they are quite symptomatic, and it's worth listening to the patients and seeing what they are. But we always try to be very realistic with what we are achieving. If the calcium's slightly elevated and we operate and make it completely normal, some of the symptoms may persist because it may not be having been driven by the high calcium.
Yeah. It's all like anything, quite individual, isn't it, really? So
it's very individual and very individual. Generally, that's true of almost all endocrine diseases, I think.
Yeah. Okay, so we're going to leave the sporadic parathyroid hyperplasia behind completely now, and start talking about surgery. So could you explain what the recommended sort of course for parathyroid surgery is in MEN patients?
Okay, so MEN parathyroid is the most commonest manifestation. Over 90% of people will at some point develop parathyroid issues, and surgery is the only cure for this condition. Now, I hesitate in using the word cure in MEN parathyroidectomy because the chance of this coming back is very high. We really counsel patients very carefully about this. And with regards to surgery, I mean, it's very individualized, and I would very much recommend talking to your surgeon, your endocrinologist, about where you are in your life. But a lot of it comes down to what you're trying to achieve and the expectations with the patient. So in the more younger population, what we tend to do is talk to them about that there are 2 realistic good options available. One is that you have a scan done, and at that point, hopefully it will show either 1 or 2 glands causing the disease. And some of my colleagues and surgeons around the country, what they will do is they will go by the scan and go down. Let's say the scan says that the gland on the right is the most dominant one on a nuclear scan, for example. Go down that one and clear that side. And what that means is take that tumor away as well as the other parathyroid that's going to be likely on that side. And again, in the MEN syndrome, you can, when we say clear that side, we try to take away any other tissue around, such as in the thymus, just to prevent any other tumors that might be there, or ectopic parathyroids. What does that achieve? Well, in that way, it's a more straightforward operation. You're just clearing one side at a time, and you know that you are safe in removing the other parathyroid gland, because it is a diseased gland. Even if it looks normal at the time, it has the potential and will eventually become diseased. What that means for the patient, however, is they will need to have a second surgery. They simply will, whatever their age is, and because the other side will eventually start to kick off. And that could be in a year, it could be in 5 years, it could be in 10 years. It's difficult to predict exactly when that will be. And when that eventuality happens, they will need a second surgery on a side that has never been operated on. So again, quite a straightforward operation, but 2 operations certainly going to be needed at that point. The other approach would be straight off the bat going with a 3.5 gland. That is to say, go in, find all 4 parathyroids or more if there are any, and remove 3.5 and leave a small amount of viable working parathyroid tissue that will sustain that patient and hopefully keep them off calcium and not needing calcium replacements. So it really needs to be very sure that that little piece that you're leaving behind is well vascularized, and that's probably why we in these scenarios we do recommend doing higher volume centers doing these type of operation, because it can prevent the complications that can occur if you take away too much and the patient ends up being on calcium for a while. Now in MEN, it's not a disaster, because you know that remaining parathyroid is likely to grow again. But you know, in young people or in any age group nowadays, everyone's so young at the moment, it's worth bearing in mind that if we can keep them off calcium tablets, but with a normal calcium PTH for as long as possible, that would be ideal. So really, those are the 2 options: whether you do 3.5 glands straight away, or clear one side and accept you will be coming back. But it just needs a very careful conversation with the patient about what you're trying to achieve and what the expectations are going forward. So and you want to try and maximize the time between surgeries wherever one can, but avoid any of the complications, the nerve injuries, the hypoparathyroid, which anyone will tell you is arguably worse than hyperparathyroid.
Yeah. Okay. And I assume, you know, that conversation is with both. You know, if you're taking half the neck, you're doing half the neck, or you're doing both sides but leaving half a parathyroid in, you've still got to think about what happens with that half parathyroid in the future as well. So I guess that can.
Absolutely right. And the things you want to do is try and, where possible, leave that remaining good, healthy, viable parathyroid in a convenient position. Now, this is a difficult one to try and to go through, but I was talking to my team recently about this, and where possible, we always try to leave one of the inferior glands, because they're slightly closer to the front, they're easier to access. The superior glands, the upper ones, are usually placed behind the nerve in closer proximity to the laryngeal nerve, and to go back for that risks injuring that a little bit more. So where possible, we try to leave the lower ones, because it technically should be a simpler operation on the next time. And that might be in 10, 15, 20 years time, but it still will be appreciated. So nowadays we sometimes go back, and if they've left a superior, it's always a little bit more difficult than if they've left an inferior. Patients have left an inferior behind from 10, 15 years ago. So it is, you're right, it's a very cerebral operation. You're always thinking about, what am I doing now? What am I trying to achieve now? But also, what am I trying to do for the future? And how can I make the patients and my life easier in 15 or 20 years?
Yeah. Because I suppose, you know, even in something generally as narrow as the neck, the more often you go in it, the more scar tissue you develop, and that complicates going back in again, doesn't it?
Absolutely. Where redo surgery is a different kettle of fish altogether. It really can become the most enjoyable, but also the most demoralizing operation. And redo surgery, again, we try to advocate quite strongly that it's done by centers that do a higher volume, just because if you can try and concentrate that expertise into a few centers around the country, it does make the patient's life much easier and simpler. Risk of nerve injury is much higher in redo surgery, considerably higher, and so you know when you get used to doing these more and more, hopefully you can try and minimize that, but it will never be 0%. So it's worth trying to maximize the time between redo surgeries.
Yes, yeah. So what are the general risks of parathyroid surgery? We've sort of touched on hypocalcemia, but perhaps you could sort of elaborate a little bit more about what the actual risks are of parathyroid surgery.
Yeah, well, we talk about this for all patients undergoing surgery. The standard ones are you're going to get a scar in the neck. The scar, I'll spend a little bit of time, is naturally, it usually heals very well. There are natural creases in the skin, and we normally try to place the scar in one of these creases so that in a year or two, hopefully looking at the scar, it fades away into a thin line and disappears. But scars, like to think, just tell a story about you and who you are and what you've been through, and shouldn't be the reason not to. Nowadays, there's more interest in robotic surgeries, and that might be taking off transoral surgery, and that might be becoming the new fad that goes over the next 5 to 10 years, and as it gains popularity. But at the moment, the vast majority of the UK is doing standard scars in the neck, and that will be decided with your surgeon. And the thing I say to people when people contact me and say, oh, I want the smallest scar possible, is you do, but you want the smallest scar that allows the operation to be safely done. And we're very lucky at the moment with the volumes we're doing, we can really try to get these scars down to a couple of centimeters, but always bear in mind, you would always rather have had a 4 centimeter scar rather than a 2 centimeter and a working nerve. So it is a bit of a trade-off to be had with scars, but that's, and again, another conversation I always have with patients. Bleeding after surgery is quite rare in parathyroid surgery. Redo parathyroid surgery certainly gets a bit more, but always be aware of the potential of bleeding in the neck, and even the smallest amounts can obstruct the airway and the need for an emergency return to theatre to evacuate that. And that's true for most surgeries, I guess, those complications. Infection, very rare in this type of area. In fact, if anything, I've seen more infections related to glues that we use and irritation to the skin, but not so much a classic infection of the from the operation itself. Then we talk about the complications that are specific to this type of surgery. And the first one is the chance that you may not be cured or have biochemical control after first surgery. And we classically say that's somewhere between 3 and 5%, depending on the approach one uses and the hospital and the center. And the reason we say that is because this is a very cerebral but unforgiving disease, in the sense that sometimes you can do what you think is the perfect operation. Everything went to plan, you found everything you wanted, and then the patient comes back 4 weeks later with the blood's all over the place and you haven't cured them. And that's because they've got an extra gland. And these glands, because of how they embryologically develop from the neck and then drop down, can be anywhere from around here down to about the level of the heart. And whilst the vast majority are in the classic eutopic position around the thyroid, they can stray and wander. And in those scenarios, we always tell people no one should be saying there's a 100% chance of cure with this type of surgery. If we can get it to around 97, 98%, we're quite happy with that. And even with the checking all the glands and using PTH testing during the operation, that's about as good as we've got in the world at the moment, which actually isn't too bad. So we do tell people about the risk of not being cured. The risk of being overcured, as we've talked about, where too many glands are removed or not even removed but damaged during surgery, leads to hypoparathyroidism, so underactive parathyroid, and that can lead to the need for lifelong calcium tablets. And depending on different people, that can be as much as 1 tablet a day, or it can be really quite debilitating where people are needing to take tablets every few hours on the clock. And there's great advances being made in those hypoparathyroid patients about what we can do to try and get them back on track. We see that less in MEN, I guess, because eventually, as long as there's some tissue somewhere, it will try to regrow, and that's the disease of MEN. But still, in those times, whether it's 1 or 2 or 5 years that you're waiting for your parathyroids to regrow, it can be really debilitating. So really one of the complications we do our very best to avoid it at all costs where possible. And the last one to talk about is the nerve, with the recurrent laryngeal nerve, which traverses both the parathyroid glands on both sides and supplies one's voice. Damage to that can be this in the shape of cutting the nerve, or even overstretching it, or using the heat, the cautery, too near it, and that can damage the nerve. We do tell people there's a small number that can have a temporary damage to the nerve. So for a few weeks, it's quite hoarse. The voice is quite hoarse, but does tend to get better with time. But in those cases where it's been permanently damaged, that would be quite rare in parathyroid surgery, but it does happen. That leads to permanent hoarseness of the voice and a very breathy voice. There are things one can do to manage that, and that includes vocal cord injections by our ENT colleagues who will help us with that. But again, hopefully with the type of surgery we're doing here, it's quite unusual. but not 0%.
Yeah, yeah. And I guess all of those really emphasize the fact that you need to see a surgeon who does lots of these with, good outcomes. So high volume surgeon equals better outcomes.
Yeah, absolutely. And there is no magic number. I think we've tried to come up with some numbers. The BATS have done some very good work in trying to decide what is a good number, and something around 20 or more would be appropriate. But also don't forget, as long as you're doing good volumes of thyroid surgery, you get accustomed to finding these nerves and seeing these parathyroids, so that there is also some utility in doing high volumes of thyroid surgery in parathyroidectomy. So yeah, where possible, especially in redo, we would recommend that definitely goes to more specialist centers. But even in first time surgery, if you're doing less than 10 a year, just think to yourself, do I want to be doing this? Is this the right thing for my patient? We do have to accept, however, the counter argument that if everyone in the country doing less than, let's say, 20 stops doing them, it means those centers doing high volume suddenly get inundated and everyone's waiting list gets very much longer. So there is a balance to be struck, and maybe perhaps a bit more training for those people doing less, but more dedicated training for them to help people out.
Yeah. No, that's great. So sometimes there could be, is that right, a temporary drop in calcium after a parathyroid surgery. So do you routinely give patients after surgery calcium just in case, or is that wait and see?
It's very much dependent on what one has done during the operation. If one gland has been removed, or two glands, and you've seen the other two and they're very normal looking size shape at the moment, it's quite unlikely that people will have a dramatic drop in calcium where they become symptomatic and have issues. We do see that there is definitely a temporary drop, which is in the first 24, 48 hours, and all patients are told what to watch out for. They're told in the first 24 hours, 48 hours, take lots of calcium-rich food. That would be dairy, milk, green leafy vegetables. And if they need supplementation, then certainly there would be little harm in taking short-term calcium supplements, which can be bought over the counter. A lot of centres have moved towards sending patients home on the same day. So it's difficult to gauge what the calcium is doing, because the calcium does take a little bit of time to drop down. But what I would say is where patients are being kept overnight, the next morning it's worth checking the calcium before they leave, so you can see roughly where they're at, and then make sure that you're prescribing things where needed. MEN becomes slightly different here, because if you have done the 3.5 gland, or you've done the redo operation where someone's already had a few glands removed and then you've done the second operation, there is much higher chance of going hypoparathroid, hypocalcemic temporarily. And usually we have a low threshold if we think there's anything to be concerned about saying either come in for some early bloods after about 3 days, or just saying, here is some calcium, start taking it, we will wean you off it with time. It's far safer to approach it that way than to allow them to become very symptomatic with low calcium, very pins and needles, tingly, having muscle cramps, and being admitted to hospital, which is much worse for the patient and for the hospital.
Yeah. So my last question is really about genetics, and I'm guessing because of the different approaches, therefore, that a genetic test before embarking on parathyroid surgery is pretty important, but perhaps it's not always applicable. Could you explain
Yeah. So where we get a younger patient, typically under the age of 45, we do try to consider genetics a bit more, where possible, the endocrinologist will usually pick up these patients and have those done beforehand. Now, times are changing, and now the turnaround for genetic tests is 2 to 3 months in our region at the moment. But there are some instances where, especially during COVID, you can imagine it was up to a year. And in cases where people have got very high calcium and can't wait the whole year, then we were referred cases to say, please just operate without the genetic testing. And you just got to be very considerate, and again, talk to the patient about the fact that the approach might have been different if we knew you were genetic. So we have to balance that again versus how we best go in, whether you just go in for the obviously diseased gland on the scan, or whether you check all 4 glands while you're in there to see if there is any genetic component. Again, this would be down to the individual surgeons, what they prefer to do. There's a few people who we prefer to do a 4-gland check on all cases, as well as use the PTH monitoring. I think that really does maximize cure chance. Of course, it does come with the fact that you are scarring up all the glands. So God forbid, if you have to come back later for a thyroid problem or a parathyroid problem, it will be more scarred up. But it's a very a conversation I have with everyone, and the risk of nerve injury slightly goes up if you're checking all 4 glands each time. And again, if you're a high volume center, hopefully that's not something that's going to stop you going in. But you really got to know your patients. We recently had someone who came in who was a singer whose voice was their career, and we spoke about that, and they said, you know what, go for just the one gland, because if we say less than 1% chance of nerve injury, it's too much for my career to be over, and we agreed it was the right thing to do. So just individualize it to the patient rather than saying, this is what I do this for everyone. It doesn't really work, I don't think, in modern day medicine, because I think you have to really consider the patient individually and have that conversation with them, so you know exactly what they want from you, and they know what our expectations are from surgery as well.
Yeah. Oh, that's fascinating. It's amazing how such a small gland can cause such chaos, isn't it, really? But,
well, we've known about, the brain, the eyes, the heart, the thyroid for centuries, but this parathyroid, it's not been long, barely not even 200 years. So it's still a newbie in the world of endocrine and organs.
Yes, yeah, brilliant. Okay, well, that was fascinating. Thank you so much for answering all those questions. I'm sure everyone's going to find that really, really interesting, and definitely a good pre-surgery watch, I would imagine, as well. So thank you so much for your time and for giving up, this hour of your morning as well. So thank you.
Oh, it's my absolute pleasure. Thank you so much for inviting me.